good. Can you guys see my slides in the right format now?
Yes.
Leave your beautiful pictures over here so I can see my slides. Great. Well, thanks for having me. I have a deck here it's about 30 slides long. I don't think that it'll take long. I'll zip through a lot of these. But just talking a little bit about our journey to longitudinal assessment. We'll have a couple slides in there about kind of how we got to that spot, what these types of assessments are going to do, why they're designed the way they are. I will tell you and hope you know firsthand, because I'll describe mine, and I'm sure you know plenty about ABP's version of this. You have seen one longitudinal assessment when you've seen a longitudinal assessment. Those of us in the space, the designs are different. And they're kind of tuned to our populations, what they were looking for and what they wanted. I'm glad to pause anywhere along, like don't feel like you have to wait to the end to ask questions. Throw your hands up, interrupt me, and we can kind of talk the way through it, make this much more conversational than a presentation. So what I thought I would do is I would start by just giving you a little context and background on the organization, just so you can kind of see where we're coming from. We'll spend some time talking about PanReLA and the kind of ways that we got to PanReLA, the route that we took to get there. And then the last half of this will be a little bit about some of the work that we're doing. One of the nice things about the position that I'm in and the organization I'm with is that we, like a lot of certification boards, we're the test owner, test publisher, test originator. We do all of our work in-house, psychometrics, exam development, all of that work's done in-house, and it gives us a tremendous amount of control on the direction of the examination programs, which means we're always tweaking and doing research and trying to gain efficiency. So look at things that we could do to build on the programs that we have. So I'll talk a little bit about the work that is kind of ongoing or just wrapping up and give you a peek in terms of where I think research is going with certification licensure, with longitudinal assessment, through some of the projects that we're eyeballing here in the next, I don't know, 2 to 5 years, let's say. All right. So PAs are a medical profession. They're kind of that mid-tier medical provider. Advanced practice providers are sometimes called. Think of them as kind of a step below physicians in terms of training and responsibilities, and then a step above the other professionals that might work in a clinic or a hospital setting: nurses, medical assistants, surgical assistants. It is relatively young, created in the 60s as a way to backfill shortages of primary care physicians, primarily in rural areas is where that started, but it has kind of grown. The NCCPA itself has been around since 1975, so just over 50 years the organization has been in existence. Hope mentioned this, but we're the sole certifying body for the profession in the US. Right now, initial certification is required for licensure in all 50 states. So even though we are a certification exam, we're kind of the de facto licensure exam. It puts us in a spot similar to the US medical licensing exam that the National Board of Medical Examiners provides in that sense. But we also offer recertification, and recertification feels a little bit more like what the medical boards do as people board and reboard. We do have recertification does require an examination. It always has since the beginning. We continue to do so. It is an area of contention with some PAs because there are some providers that do not have to recertify using an examination. And so we hear about that sometimes, and it actually kind of drove us in the direction of longitudinal assessment. About a decade ago, we started exploring this. Recertification is only required for 18 states, but about 96% of PAs maintain their certification over years. So even though licensure requirements, it's less than half the states, and that number decreases each year, almost everybody maintains their certification. There's a lot of external pressures to stay certified because payers, insurance companies and payers pay at a higher rate, because hospital system credentialers, malpractice coverage and insurance is less if you have the highest level of certification degree that you can. So there are other pressures that PAs are under to maintain certification, it makes them kind of unwilling participants in the system sometimes. And again, that also kind of featured in as we rethought about recertification. What do we do? How do we make it relevant so it doesn't feel burdensome without purpose? We have 317 PA programs. 10 years ago, there were half that number. We are growing at an astronomical rate, the profession. Every year we add anywhere from 3 to 7 new programs, each with 30 to 50 new PAs. Means that we have about 5 to 10% growth year over year. PAs are trained in a medical model. It's about a 30-month long program on average, and it results in a master's degree. Medical model means they do this year of didactic medical training, but it is focused largely on clinical rotations towards the end of their training, where they are spending time learning from clinicians, from preceptors, shadowing at the beginning, and then participating in procedures and clinical experiences as they get towards the end. PAs are a little bit different than other professions and some of the other medical boards, some of the other organizations. The curriculum is truly focused on producing generalists, people that understand medical at a very broad level. They don't go to residencies, they don't pick a specialty area out of PA school or in PA school and then move through additional training. They finish their program, they graduate, they take a job, and those jobs are sometimes in specialty areas. In fact, most PAs are working in specialty areas. Only 25% at this point in time are working in primary care areas, so family medicine, general pediatrics, general internal medicine. Everyone else is working in a more specialized context, but that's not where their training is. The other thing is that they can, I'll get to that in one sec, Henry, because that is a good point, and it actually kind of features in another way that the PA organization is different. PAs can change specialty throughout their careers. That means that if you can find someone that'll hire you in a different practice area, a different specialty area, you can change. Your medical license is not specified. So you could be working in dermatology today, and an orthopedic surgeon will hire you tomorrow. You can be an orthopedic surgery PA tomorrow. Most PAs change at least once in their career. We think that number is about 70% change to some degree. Sometimes they're pretty similar change, and you go from the emergency room to the urgent care, or from critical care to just a general hospitalist. So sometimes it's not a big change, but we think most PAs change at least once. Some change several times. Because of this, our certification and recertification programs are flexible and meant to be general. The idea is if we're saying that you can go practice anywhere, we have to test you on a little bit of everything. And you can imagine that is not super popular for a highly specialized PA working in psychiatry to sit down and recertify, where only 6%, 7% of the exam deals with topics that they see in the clinic. That domain is really big, and they're answering questions everywhere. So Henry asked a question about PAEA and NCCPA. There are 4 organizations that kind of govern the PA profession. There are 2 that are kind of more regulatory in nature, and CCPA is one of those. The other one is called ARC-PA. ARC-PA accredits PA programs. So they essentially say that the program meets these standards and can produce students. We only let students that graduate from accredited programs sit for PANCE. So the only ones that can get a medical license as a PA. The PAEA, the Physician Associates Education Association, represents the programs themselves and the faculty within those programs. So they're not dealing directly with the students, but rather with those who provide PA training and programs. Hope was mentioning his dissertation work, and his research deals with some of the in-training assessments. PAEA provides in-training assessments. So they do assessment work. So a testing company, much like NCCPA, but it's really geared for the assessments that are done in the training process. NCCPA is at the end of that program, and our job is to make sure that those that graduate are prepared to enter the profession. So our kind of domain is, what would an entry-level professional need to know in order to be a safe practitioner? Mark, it's about 16,000 people test per year. First-time test takers are a little smaller than that. We have some repeat test takers who weren't successful the first time. That number is more like 14,000, nearly, we might get to closer to 15,000 this year, which is sizable, but small if you compare it to some of the other medical professions. Nurses produce, I don't know, 1 million graduates a year. The NCLEX has an enormous volume. Same physicians are larger in terms of number of participants, but it's bigger than a lot of the specialty boards. Don't produce quite as many graduates. So you would see in some of the smaller medical professions, smaller numbers of people coming out of those programs. Any PA questions, anything about the profession, about kind of where we sit in the profession before I move on? The real key here that I wanted to highlight is just that general training model and the fact that even though PAs are trained as generalists and are certified and recertified as generalists, most are practicing in specialty areas and do so throughout their career. We kind of have 3 different courses or 3 different tracks of assessment programs. We actually have, if you count the 2 research programs and all of our certificate programs, 14, 16, 17 exam programs. Many of the CAQs have a maintenance program as well. They're actually separate, and we build those exams separate. If you include those, it's more like 24 exam programs that we run, which takes a fair amount of staff, effort, time, content development, all of that. PANCE is our initial certification exam. It's the Physician Assistant National Certifying Exam. You have to graduate from an accredited PA program. So our PA has to work with the program. They meet standards. You graduate, you're eligible to sit. Right now, ARC is only accrediting programs in the United States. That is poised to change at points in the future. And we're looking at what we might do as the PA profession kind of grows internationally. How do we need to be prepared to talk to, deal with, onboard international candidates that may want to practice in the United States, or maybe using our certification as justification for practice in their own home environment? PANCE is a general medical exam. It is very broad, mile wide, mile deep. Anything under the sun is testable on that PANCE exam. It is a traditional linear form. We build multiple fixed forms each year. We release them at the start of the year. They're out for a year. It's 250 operational items, 50 pre-test items. You can test at a Pearson VUE Testing Center 50 out of 52 weeks a year. If you can find a date, time, space to go test, you can get an appointment and go test whenever you want as a graduate. First time pass rate's about 92%. It's pretty high. That's not atypical for folks that are coming out of medical programs, master's or advanced programs, to have a high pass rate. We do see a fair amount of repeat test takers. You can only take PANCE 6 total times in your career. If you don't pass by the 6th attempt, you are no longer eligible. You also have 6 years to take that examination. That's something that is under review by our board of directors now, but that's a long time to not be in training to then sit for a general medical exam. So my instinct is that they're probably going to dial that back here in the near future to make your testing period closer to your time of graduation. PANRE and PANRE-LA, as the recertifying exam, are our 2 pathways. In 2019, we've had 2 different pathways. We started piloting a longitudinal exam. We still have a traditional fixed form exam, much like PANCE. About 18% of people opt for that, or they just forget to apply for the PANRE-LA perhaps, but they're not in the longitudinal program. You have to pass one of these 2 exams every 10 years in order to maintain your certification. The blueprint is a little bit different. For many years, until just recently, the PANCE and PANRE blueprints were the same blueprint. Our expectations graduating from your program to recertification were exactly the same. One of the things that we did as we re-examined recertification was to ask the question, does that make sense? Does it make sense to test someone that's been practicing for 30 years on exactly the same thing we would test a new grad on? Is that domain the relevant domain? The answer we came up with was no, but we do need to maintain this core fundamental knowledge that is limited in scope, but broad in scope. And so I'll talk a little bit about that in the slide. Our last set of programs are specialty programs. These are for PAs that need an additional credential in their specialty practice area or would like one. They are smaller. They're 120 items, all multiple choice, delivered in the test center. We have 12 active now and 2 more that we're developing. My guess is we'll probably get to somewhere around 20, 25 specialty certificates over the next, I don't know, 5 to 8 years. We'll continue to add them. And it'll cover most PAs in practice by the time we're done with that. We'll have most of the big practice areas kind of covered. All right. So I just mentioned that about 10 years ago, we took a look at recertification with the following kind of points in mind. First is that most PAs are working in specialty areas, non-primary care areas. And what does that mean for our testable domain? What should we be testing people on? We heard over and over again that a broad generalist exam did not make sense to the way that most PAs were practicing in clinic. And honestly, if we look at just broad testing in a linear traditional exam, it's not really great protection for the public, right? What we are encouraging people to do is take 2 weeks off, take a boot camp study course, cram, pass their exam just barely, and then brain dump everything that we made them learn because it wasn't relevant. They're studying cardiovascular system stuff, and then they dump it out on the exam, they leave, and 2 weeks later, they're back in the dermatology clinic, and they're not thinking about it anymore. And so it just isn't great protection. We should be doing things to ensure maintenance of knowledge over time, not can you demonstrate this right now. So we took a step back and said, what should we do? How do we modernize recertification? We did a lot of quantitative and qualitative studies, focus groups. We had some summits where we invited representation from various PA groups to come talk to us. We surveyed, we asked other organizations, we asked employers, we asked medical boards, anyone that would talk to us. We asked, what is it that you need in recertification? What makes a valid recertification? What should that mean? We did lots of research on knowledge retention, spaced education, adult learning, test-enhanced learning, with the lens of what can we do to base this in the research that would allow us some assurance that we were building PAs that would maintain competence over time and not just kind of do the brain dump that you might do on a recertification linear exam. So we made 2 decisions. The first was to shift from broad medical knowledge to core medical knowledge. Essentially, what we did was define a list of testable content. We have a published list of medical content topics that we say, these are the ones that are relevant, and these will only be the things that we test. There won't be any topics that aren't on the blueprint that show up on the examination. The second thing we did was we defined the scope of clinical practice. We said, how much do you need to know about these things? So there may be some things that are very important for you as a PA to be able to recognize and say, well, time to send you to the emergency room or time to refer you to the specialist, but there's no way I'm qualified to treat this condition. So we have some of those topics. I need to be able to recognize signs and symptoms. Maybe I know risk factors. Maybe I can do initial preliminary examination, physical examination, history taking, those types of things. But without the expectation that I make a diagnosis, read the labs, read the tests that come back, and design a treatment plan for those individuals. There are other things where you might need to know everything. So hypertension, diabetes, pneumonia, flu, things that everybody sees all the time, you should know a fair amount about. Other topics fall in between, right? Where we need to be able to diagnose, but maybe I'm not doing the treatment, so on and so forth. That blueprint was implemented in 2019. We updated it in 2023. We have a practice analysis that we're planning that will look at it again this year. So we're going back at to say, is that domain of core medical knowledge still the right domain? Are there topics we should add or subtract from that list? The second thing, and probably more consequential, was we decided to pilot an alternative to the fixed exam. We had to kind of time this carefully because PAs at the same time were moving from a recert cycle that was 6 years long to a decade long. And so we wanted to pilot before we lost recertifying test takers for a period of time. So in 2019, we launched this pilot. We allowed people to opt in to that. who were due to recertify. 18,000 people participated. It was about 60% of those that were eligible. The other 40%, probably more risk averse, took the recertification exam as it existed, the fixed form version of that. About 98% of those that participated completed or signed up completed the process. About 97.5% passed. So a higher pass rate than we typically see in a recertification examination. It embraced a spaced or longitudinal assessment format. And so I'll kind of dive into that now and talk a little bit about what this is. For those of you that are more familiar with the K-12 environment, these types of assessments exist in a slightly different form in the K-12 world. We sometimes talk about benchmarking, or you might hear about through-course assessment, where the assessment gets a little bigger throughout the year because there are new objectives, new content that's taught tied to a curriculum map. The kind of intent is the same, though, is that smaller and more frequent assessment allows us to do more things than testing at one point in time. So for longitudinal assessment, the idea is to repeat assessments over a defined content domain over time. Our content domain doesn't change. It's core medical knowledge. Anything from that domain is fair game throughout the course of the assessment. In K-12, you might see we're only covering the first 3 objectives in the first quarter, another 3 objectives in the second quarter. We can test on those first 3, but we're going to add these 3. So it gets a little bigger over time, where we say this is the domain and we're just going to test you in smaller increments over a period of time on that domain. The key here is that we provide immediate feedback, and it's typically coupled with self-assessment. So you answer the question, and I'm going to ask you, did you feel confident in your response? Is this similar to the work that you do every day? Is it relevant to your day-to-day work? After they answer those questions, we tell them immediately, you got it right or you got it wrong, and we provide a rationale. Your answer was wrong because of this. The right answer is this, and here's why. Here are some references that justify, the correct answer, the incorrect responses as being incorrect. And that's a real powerful combination to have to assess how well you know knowledge and then see, did you get this right or wrong? You can imagine if I said, I do this all the time, I'm confident in my response, and you get that question wrong, that should trigger something in you, that you have this knowledge gap that is highly relevant to the work that you do. It's a big red flag. But you may also run across a spot where you encounter content and you really don't know it, and you say, I have low confidence in this, but I don't ever do this. And you see that that question was wrong. Again, it makes you check that knowledge and say, oh, that makes sense. In either case, it makes you ripe for remediation, and it makes you ripe for being able to continue to build that knowledge domain. We want to be able to target delivery of content in each different quarter that you move through this process based on what you demonstrated you didn't know, right? I missed these topics and they are important topics, and I say I need to know these topics. You're going to see those topics again. You get another chance after revealing that knowledge gap might exist. Something that we're exploring, I'll talk a little bit about this, is we may be able to move beyond this. We have about 300 topics on the Pan-LA blueprint. I can't test them all, but we do know across the whole pattern of all of those topics, what types of topics you may or may not know, right? I might be able to use some predictive modeling to say, based on your responses, what you get right, what you get wrong, your confidence, your relevance, where you practice, what practice area, how long you've been practicing. These are also topics that you might have trouble with, right? It's kind of preemptive knowledge gap identification that we might be able to use through some predictive modeling. That's kind of next phase for us, is trying to explore some of that space. The end goal for us is to ensure that maintenance of knowledge is there, that you are keeping up with the medical knowledge you're supposed to with this general medical license that allows you to change specialty areas over time. The key here is that this process is multiple years. It's not a one and done test. It spans over time. I think ours is less aggressive than some of the other longitudinal models that are out there. I'd like to see us test more. Some of those programs are persistent. The American Board of Anesthesiologists, they test all the time. They are constantly in their longitudinal testing program. Pediatrics has a small gap time, but it's 4 out of 5 years. You might fulfill your requirements in 3 years, but 4 out of 5 years, you're in that longitudinal process. Ours is more along the lines of 30 to 40% of your time. So 3-ish years, you're engaged in a longitudinal process. I think that's an area where when we redesign it, maybe a little bit bigger than that. The key is that we based all of this on adult learning research. 3 big things for us, which is the direct effects of testing. There's good evidence that material that is tested, you remember it better than when it is not tested. The simple act of knowing you have to prepare and you will be tested does something different to your long-term retention. Spaced repetition is another big aspect of this, and this leads to the multiple year, multiple chunks piece. There's a big benefit in frequent testing as long as there is distance between those points in time. One of the big questions I get from PANRE-LA PAs is they're like, I finished a quarter, why can't I just take the next one immediately and just keep going until I'm tired? And the key is that spaced repetition tells us that that is not the optimal way to retain that information. Distributing that information, practice of those activities over time is superior than to pushing everything into a single testing instance, right? It's just better at retaining that information. And the last is the effect of the assessment format. We get better impact of all of these things when we force application of knowledge, not recall a fact, when we get that immediate feedback, when we make you self-assess the content. All of those things coupled together are a really powerful combination for knowledge gap identification and then long-term retention of both things that you demonstrated knowledge of. You didn't have a knowledge gap. We kind of double down and support and reinforce that knowledge. But also those gaps that we then remediate, there's better retention of that remediated information if we can push it into a format that is supported by these particular features. Any questions about longitudinal assessment? I'll talk a little bit about our system, how it's set up, because it'll kind of prime us for some of the research we're doing. But any questions on that setup, the process of longitudinal testing, or why we might be doing that kind of work? So I'll tell you just real quick, high-level overview of PANRE-LA. PANRE-LA is delivered in 3 years, 25 items per quarter across 3 years. Every item is individually timed. You have 5 minutes to respond to that. This was one of the features of longitudinal testing. It's one of the things we hear from PAs is that oftentimes this feels a lot like practice. You walk into an examination room, maybe you look at a medical chart, you ask a few questions, you may order a couple labs, and then you step out of the room. You have time to process information. You have time to maybe look up information, retrieve information, go back into the room, and you interact with the patient again. And maybe it's with the diagnosis, maybe it's with the treatment plan, whatever it might be. Right, so they like this idea that there's time in between, and I'm dealing with one topic at a time. You have 3 years to complete those 8 quarters. It's 12 total quarters. It's in the latter half of their recertification cycle. We did add some flexibility to this compared to our pilot. You can skip up to 4 quarters. You have to complete 8 quarters of testing. But you can skip 4 along the way if you want. You could take the 4th quarter of every year off if you wanted to. You can also take 8 quarters in a row and skip your last 4 quarters if your performance is good. It allows you to self-pace throughout each one of those quarters. You could log in and take 1 question a day for the first 25 days if you wanted to. You could take 5 items every Saturday for, every Saturday in the quarter. Or you can do what about 90% of PAs do, which is log in once in the last 2 weeks and answer all 25 questions at once. By and large, people like having the flexibility. They're not using it, but they like the idea that I can log in early, I can log in late, I can do it all at once, I can take a few items at a time. And it offers them the ability to navigate that environment. You could exit in as few as 8 quarters based on your performance and participation. You have to complete 8 quarters. And if your performance is high enough after 8 quarters, you're done with the process and you go about your way. Could be the first 8 quarters. Again, you could skip along the way, but when you hit that mark of completing 8, we begin the process of scoring you and comparing you to the passing standard. You can exit at that point. If you're still below the passing standard, you can continue. We always score your best 8 quarters. We have a process where we entertain that best 8 combination for those PAs that remain in the program after 8 quarters. It's always based on the same number of items, same number of topics as any other PA that's taken the exam. If for some reason you don't pass PANRE-LA, the great news is the PANRE, the fixed form, still exists. We've timed this so that you're done in year 9. And if you are not passing, you still have the last year while your certification is valid to sit for that fixed form examination up to 3 times. And that opportunity to pass still exists. So there are multiple chances to maintain your certification. PANRE-LA is just the first one that you might take. We do target questions beginning in the second quarter. The first quarter, you get 25 questions. After that, we identify 5 potential knowledge gaps, and you're going to get a topic on one of those knowledge gaps. It's going to be something you've seen before. It's likely to be a question that you missed, and it's likely to be a question, if you've missed lots of topics, that we've identified as particularly important for you, probably because you told us that it was very relevant to your clinical practice. You missed it. Maybe you exhibited some confidence in that incorrect response. Those are going to be more ripe for remediation, and so we push more of those in. We also use an information criteria to try to match difficulty as much as we can for those topics to somebody. So if you are performing relatively low, what I don't want to do is remediate you with an item that is really difficult, right? We're trying to match that as to the degree that we can to meet both of that knowledge gap criteria, but also choose something that's psychometrically appropriate for your current performance. You do get to preview content. We tell you, are there tables or graphs that you might have to look at? We tell you what the topic area is. You are allowed to defer up to 5 items for later. We call them, kind of put it in the pocket. So let's say that you're really bad at neurology and you want to save all your neurology questions to the very end so you can have your neurology textbook open and be ready to look things up. That's totally fine. We tell you it's a neurology item. You say skip it, proceed to the next one. So it allows you to kind of self-navigate through. We don't tell them the exact topic, just kind of the broad medical domain that it will be covering. You're allowed to use references on PANRE-LA. You can't use people. We do ask them, and we have some prohibitions on how you might use AI. We ask them to use an AI using keywords is fine. PAs use Open Evidence, which is an AI chatbot, all the time in practice. I like that those resources are available for my medical clinician. I want them to have the best information available, but I want them to use it the way they would in clinic. They wouldn't cut and paste a vignette and the answer options into that. They would use keywords, they would use features, they would use lab findings and say, given these things, help me think through this question. So we have given them some guidance on how they should use those online references, that they should not be taking screen caps of items and sharing them and posting them. We do have to work to have those things taken down because inevitably they do show up in an unproctored examination. There are some people that skate those rules or aren't aware of those rules or don't listen to those rules. They get immediate feedback. Did I get it right or wrong? And then you get a rationale behind that immediately. And we provide some good instruction that the things that you miss are likely to come up again, right? Make sure that you mark that for review and they have the ability to put a little check mark by that item and they can recall that information later in the process. Before you start your next quarter, maybe you want to review the 6 topics you missed, knowing that you're going to see 5 of those 6 topics in that next quarter. We also offer continuing medical education for this as well because of the self-assessment practice, the fact that you have to stop, pause, think about your kind of internal expertise, and then it is coupled with this opportunity to remediate those knowledge gaps. That's kind of PANRE-LA in a capsule. It's 3 years long, 25 items every quarter. Some of those are repeated topics, targeting areas where we think you might have knowledge gaps. Any questions before I move on? All right, let's talk a little bit or show you a little bit about what this might look like. This is a retired item, but it is one that was used actively for some period of time. You can see the little timer up in the top counting down. There's a reference lab value that pops out if you need that. You would get the question, you read the question, you make your answer, you choose your answer. If you run out of time, it is scored as whatever you have selected, and we score each item even for timeouts. So we do encourage people to choose something, choose what you think is the best answer before you go research. So you're not scored on a zero response. After that, you get the self-assessment piece. What's your confidence in the response you provided? You get to see the question. How relevant it is to what you're doing? Do you think this content is up to date? We do use that to help us determine if standards of care have changed. And then internally, we are always curious, did you use a reference to answer this, yes or no? We can't verify that they're giving us true answers there. We think for the most part, that the self-assessment most people are using, at least to some degree, as intended. Some are probably just clicking through and hitting submit. That is an area of research that we're looking at. How much can we use that and depend on those? At the end, you get immediate feedback. Did you get the item right? And then you get an explanation behind it. This screen is accessible to the PAs throughout the entire process. So every question they have seen, all the content they've seen, they can go back, they can find it. It's sortable, it's filterable. You can say, give me all my endocrine items. You can sort it by ones I got right, ones I got wrong. You could sort it by topic to see if you've seen two items on the same topic. That would tell you you've already had that knowledge gap remediation chance and that one's not coming back up for you. So it is a tool that's pretty flexible, but it puts all of that information at their hands so they can use that as they progress through the assessment. Big item bank, lots of topics. We publish one per year. It's about 700 items. We produce 3 items per topic. They're different and unique items. And the idea for us is if we're remediating, I don't want to give you the same item, right, with the same key. It is a different look at the same topic, written to the same level. And then we include a fair number of topics from the prior year's bank so we can equate the scale over time. It is one reportable scale metric over time. The form is assembled individually for each person on the fly. You hit go and we assemble the template when you, or the template when you hit go. The first item is random. After that, we use an automated assembly process to build to the blueprint. We always choose the remediation items first, and I'll talk about that process in a minute. And then we backfill the remaining topics to meet that blueprint. The idea is by the time you get to the end, you've met the entire blueprint set of constraints. We calibrate it the first quarter of every year once we hit a minimum N. We use a neat design, so we're using the banked parameters from those old items from last year to pull the new items onto the scale. We only use first attempts. We do not ignore the second attempt because we believe people interact differently with that repeated attempt. They do better. So it is only people the first time they have seen a topic are the only items used in this calibration to pull those new items onto the scale. We flag, review, and remove items from scoring in that first quarter before we post scores. It has been a big deal for us, and not all longitudinals are doing this, that we want scores available all the time. So you can see where you compare to the passing mark over that entire process. The only time you don't get immediate scoring feedback is in that first quarter because we're waiting to calibrate. Typically, scores are available at the end of that first quarter and always before the second quarter of the year. After that, as soon as you finish your score updates in real time, you can see immediately how you did. Did your score go up? Did it go down? How do you stand compared to the standard, compared to the overall mean score, so on and so forth. If you do get 2 topics on a knowledge gap, we score the better of the 2 attempts and remove the other attempt from score. So it's kind of optimized for each PA. Whichever gives you the better score, that's the one that we're going to use. So we use 2 factors to choose those knowledge gaps. We use that self-assessment data. For me, a big red flag is someone that gets an item wrong that they tell me they are highly confident in, and it's work that they do every day. That's a big red flag. I want my cardiologist to know cardiology, be confident in cardiology, and get that cardiology item right. If they're not doing that, we need to remediate those items. So it's using that pattern of kind of red flag items coupled with just the Fisher information criteria. So we look at your current performance, the location of that item on our scale, and we try to choose an item that is optimized both for those self-assessment criteria, right, wrong, and confidence, and which one of those is best suited for you. We choose the top 5. We have this ordered list. It ranks them from most desirable to least desirable for any item that we could remediate. And then we choose the top 5 each quarter. You only get one chance to remediate a topic. You don't get to keep going, even though we have multiple items in the bank. After 8 quarters, you're done if you're passing the exam. If not, you continue on. And we go through a process of finding your best 8 quarters. So let's say you get to the end of the 8th quarter and you're not passing. You would take the 9th quarter. We look at all possible combinations of 8 quarters from that 9. So it's, 9, choose 8. We look at the best possible score. If that score is a passing score, you exit. If that is not the case, we take those 8 quarters, you get another quarter after that, in the 10th quarter, we go through that same process again. So you get multiple attempts to exit the exam. You can exit as soon as 8 quarters have been complete. That's the first time we'll consider exiting you from the PANRE-LA. Lots of promise and pain with PANRE-LA, with any longitudinal assessment. We think we can fill knowledge gaps, and that's great. Better and consistent practitioners over time. We think it's a more authentic format. 5 minutes of time, you interact with content, you can look things up, you can interact with the content, process the content, check your assumptions. That's great. It leads to better retention of knowledge, definitely more flexibility, reduced anxiety. Those last 2 we hear all the time. From just a customer service perspective, those are the things we hear the most. Is I love not having to go to the Pearson Testing Center. I love being able to do this where I want, when I want, on a Saturday in the morning, Sunday afternoon, at work, whatever it might be. They feel this great reduction of anxiety of the way that the content is presented to them. Lots of pain though. Item hungry. This is an unproctored examination. They have 5 minutes per item. It means for me, by and large, the items we administer in a year, 700 items that we write painstakingly each year, it takes an incredible amount of effort. They're done. Except for that small number that we keep as overlap items, we retire those items. They can't be used again. We consider them exposed. Lots of test security concerns. Is someone answering this the way that we intend? Are you using your buddies, your friends? Are you crowdsourcing your answers? Are you taking screen caps? Are you feeding the entire vignette to ChatGPT? Like, those are all concerns for us. We know that ongoing testing is hard for test takers. You're not done after 1 attempt. You're in this process for at least 2 years. Most people go into that 3rd year, at least for some period of time. It's also hard for us logistically. Think about having test takers testing all the time, year round. We have new standards, we have new blueprints. You have to figure out all of those logistics each year, every year. Right now we have 2 passing standards in place. One cohort passing with the old standard, one that is compared to the new standard, and we have to maintain both of those. Both our IT side is doing that, and then also all of our QA work we do has to remember who's at which stage compared to which standard. So logistically, it's just challenging to do. These are high stakes decisions. At the end of the day, your recertification is based on it, but it is a low stakes environment. We're trying to check that learning box, but we're also trying to make these high stake decisions. And there's always the question of, is this format, is this structure, does it lend itself to the decisions that we're making? They're life-changing for some people, the PAs. They're also life-changing for the public, right? We have an onus to the public to put qualified practitioners in the world. And have we created a format where we're not able to catch those that should not be practicing because the format doesn't lend itself to making those high stakes decisions? I'm going to pause because we're getting relatively close to time, and I was just going to talk a little bit about the research that we're doing. Any questions about the longitudinal format, the practice, what we're doing, questions about, structure or design? All right. Yeah, go for it.
Ask one question. Is there
Sure.
a rationale behind the 3 years, the 12 quarters? Is there a rationale behind the 12 quarters?
I, 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 I wish there was a better rationale for it, actually, Hope. I wish there was a better rationale for it, actually, Hope. The initial proposition, so, when you're a psychometrician and you go to your board of directors who are all PAs and have to take this examination, it's kind of selling the product that they don't want to them. And so our proposition is there should be 2 5-year cycles. Each should be 3 years. Actually, I think we said 4 years, but you could finish in as soon as 3. And then you get that year off and then you have to do it again. And they were like, whoa, 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 whoa. So you're telling us that we need to be testing twice, at least 6 out of 10 years, maybe as many as 8 out of 10 years. So it felt like it was a negotiation with those end users who were trying to find what's desirable, with us pushing back and say, but it also has to be sufficient. 3 years is kind of the compromise that we reach. That's enough time for us to test the broad domain, to have some of the spaced assessment benefits of knowledge gap retention, identification, and retention in place. It had to be at least so long to meet those standards, and we could not move less than that. But those end users were like, but make it as close to that as possible. Don't make us do more than you think you need us to do. I personally think that we fell short of that mark, and we will move into a spot where Panorama Relay is going to be 10 years old before too long, and we're going to have to think about what it looks like in the future. And I do think one of the propositions that we'll bring forward is that maybe we need to extend the amount of time we're doing this. Maybe it is more years, and we do 4 years or 5 years, or maybe we go back to that initial proposition, which is let's do this twice. You do it once in the first 5 years of your cycle, and you do it once in the second 5 years of your cycle, years 1 through 3, and then years 6 through 8, or something along those lines. Yeah, I mean, I don't know if there's a policy always trumps psychometrics when you're dealing with a board of directors. I can bring great information, great evidence, but at the end of the day, my board of directors makes policy decisions about the assessment. And that almost always overrides, what we would like. What I have to fight for is for what's vital. I feel like 3 years is kind of baseline minimum of what we needed, which is probably why we landed at 3 years. Next time I can make a bigger fight for it. Everyone loves it and no one's complaining. So why can't we do a little more benefit? So we kind of incrementally work our way there.
Thank you. Yes, Stephanie.
I have a question about something that you mentioned about frequency. I think it was maybe 5 or 6 slides ago. Something that is written in the slide is not very clear for me. Before their space repetition.
Space repetition.
I don't understand what you mean by benefits of frequent testing are increased if testing is spaced in time.
If we're going to test people over and over again, we get more benefit if we do that with spaces in between each of the instances. So think about, I need to test, I'm going to do 25 item testlets, and I'm going to do 8 of them. I could give you in 8 straight days, 25 items. The next day you come in and do 25 items. The next day you do 25 items. I could break that up into these frequent events. We get better retention of knowledge if there are gaps between those testing instances. So rather than in 8 straight days doing those 25 items, doing them with a month apart would be better. Doing them with time between would be better. There's something about that retention of memory, our ability to retain that information with that repeated testing. If there's time in between to remediate if that's happening, to reflect, to connect, it just leads to better experimental outcomes. This is literally putting a little bit of time between those testlets. The optimal time, honestly, there's an abundance of studies out there and none of them agree what the amount of time is. They do all agree that time is better. Space between is better.
How do you control for this? Because you mentioned that many practitioners just do everything at the end. So
they do it all at the end.
Is this a suggestion you make?
We do. I mean, we always suggest a lot of things. And one of the things we do suggest is sit down and test, take 5 items. If you're doing great, sure, continue. If you hit a hard spot, take a break. That's one of the things that we do to encourage people to take that space between. Very worst case scenario, if they test all at the end of quarter 1, and a lot of them do at literally the last day in the waning hours of the day where the platform shuts down, they'll go in and take the 25 items. They have to wait at least 2 weeks before they could take the next quarter, because there's a break between those quarters. So bare minimum, they have that 2 week forced break time. They end on March 10th. The program doesn't open back up until April 1st. They have at least that period of time. Most people that are testing the last day of quarter 1, they're also testing the last day of quarter 2 and the last day of quarter 3. People are pretty consistent. So they are kind of self-pacing because they wait to the end every time. Bare minimum, they'll have 2 weeks between each of their testing instances.
Okay, thank you for the clarification.
We're fortunate that some degree. Sure, yeah, absolutely. Yeah, Henry.
Yeah, thank you so much. I think you've mentioned remediation a couple of times now. I just to ask, what do you mean by remediation? Does that mean fixing the items, the test, and how is this done?
So for remediation for us, and it's different in different places. I know American Board of Pediatrics uses what they call exact repeats. And so remediation for us means if you missed a topic, really any topic could be a remediation topic. It tends to be topics you've missed. We're choosing a partner item. So because our items come in sets of 3, we rate 3 items on the treatment of essential hypertension. They're 3 distinct topics. They don't look the same. We try not to write enemy items. They shouldn't include each other. They don't have the same answer key. They're 3 items written on the same medical topic, but they're distinct items. A remediation pair is when I identify an item for you that is a knowledge gap. Typically, it's an item that you missed. It's an item that your self-assessment of the content suggests that you would benefit from looking at this item. It means that you answered with higher confidence, or you told us that it was something that is particularly important to your practice and you missed it. Those items are remediation topics. We choose the top 5. We kind of have an index that we've created. It's pictured on this slide over to the right. It's this index of your performance coupled with information. We rank every item that you could possibly have a knowledge gap on based on that index. We choose the top 5. Those top 5s are the ones that we think are the topics that you do, in fact, have a knowledge gap on and would benefit from a repeat topic. Remediation is the process of finding that topic and administering the second item on the topic, and then scoring both and deciding which of those 2 will include in your score. So it's that way of finding the knowledge gaps and retesting that knowledge gap.
Awesome. Thank you.
Sure.
So I have a question.
Sure.
Can someone lose their licenses based on their test results?
Potentially. They could lose their license. Only 18 states require recertification for licensure right now. So it's in one of those states, if you lose your license or if you lose your certification, you could in fact lose your license to practice. More often than not, what we see is a potential change in employment status. It's possible the place that you were working won't let you work there anymore if you lose your certification, right? If you're in state of Georgia, does not require a PA to maintain certification to have a medical license, but every hospital system does. So if you're a hospitalist and you failed PANRE LA, you failed all your PANRE attempts, and you lose your certification, Grady Hospital System will say you can't work here anymore. Now, they're still licensed to practice medicine, and there are lots of practices that would hire you in Georgia, even if you're not certified because your license is still valid, but it may change your employment status. The VA, another huge employer of PAs, the VA requires everyone to be certified. So you can't work at the Veterans Affairs Hospital or clinic if you lose your certification. So it could lead to the loss of licensure. It could also lead to a change of employment status based on the loss of that certification.
Okay, thank you.
Sure. Debus,
Hey, Josh.
how are you?
Yeah, I'm doing good. Just, I'm just curious, so this new process, how long has it been around, and um, do you see any much more quality PA feedback, if you want, in the field? Like, I know it was like fixed form, 250 items, one sitting, and then 5 years later. But now it's more like formative. I tend to think of it as more formative, all right?
Mm-hmm.
I don't know, but is that producing, if you want, the quality of the PA coming out or staying current? How much of that makes a difference? And I'm pretty sure there should be some differences. Okay.
So this has started, the very first group, certification licensure group to start this process was the American Board of Anesthesiology. They rolled out their MOCA Minute, Maintenance of Certification Minute. Theirs is a minute-by-minute program. That was a couple years before we started our pilots. That would have been like maybe 16 or 17. So that has been around for about 10 years. Pediatrics was shortly thereafter. We were kind of third in the game. At this point, all the medical boards, all the ABMS medical boards, all have a longitudinal component. Most are similar to all the ones that we're doing, whether it's anesthesiology, pediatrics, us, ABIM. They all have kind of similar structure in a lot of ways. So it's a maturing assessment design. It is still in its infancy if we compare it to every other kind of test format that's out there. Your question is the big question. I will tell you right now, PAs, everyone that has a choice between taking a secure examination or a longitudinal assessment, most people opt towards that longitudinal. We allow people to take the secure fixed form exam. I tell PAs all the time, I am the worst procrastinator, and I would absolutely forget that I have a quarter that I have to do questions. I'm taking the PANRE. If I'm a PA, I'm fine. I'm confident in my ability. I know my medical knowledge is up to date, whatever it might be. I'm going to study and I'm going to go take the PANRE. So that pathway exists for people. 83% of those eligible last year signed up for PANRE LA. And overwhelmingly, what they tell us is if I have to do this, I want to do it this way. They self-identify knowledge gains and learning effects in this. They will tell us that they feel like it keeps it up to date. They appreciate when they miss an item. They see they missed the item. They internalize they missed the item, but then they have that chance to answer that topic again in another format later. They recognize that that opportunity is there and that those connections exist. And they believe that it's helping them maintain a fund of current medical knowledge. We see, and I have a couple of slides I'll zip for one of them here at least. We have some evidence that we see learning effects, that we see that the second attempts for the same people using a common person equating design, if we look at first attempts versus second attempts on the same item, same people, and we hold constant estimated data on their first attempts, you can see that red line drifts to the left. The second attempts are easier. Now, it could be because they're exposed and everyone's cheating. I don't think that's the case. And I don't think that's the case because the stakes of this, as you mentioned, are so different and so formative in nature. We've reduced a lot of the motivation to cheat from this exam. It doesn't mean that people aren't trying to engage in dishonest behaviors, but by and large, I think people are engaging in the process, and the items are easier on the second attempts. These aren't the same items. They're not the exact items you see on that second attempt. You're seeing a different presentation of the same thing. And still we see people perform better when it's their second attempt on a topic. So I think there's some evidence that learning is taking place. We have a lot more work to do in this. If you want to think of it from a validity argument standpoint, we're making some pretty strong claims about knowledge gain, knowledge gap identification, and remediation. And we have some evidence to support that. What we're doing now over the next several years have identified other things that we think will help us identify. Are those gains real? both through some qualitative inquiries and through gathering, examination of endpoints and performance overall, identification of growth over time on topics, all of those things we're working on. So we're getting there. I don't think we have all the evidence in yet to suggest that it is the learning tool we'd like it to be. But, it's that process over time. 10 years in, it shows promise. I think we still have some work to do.
Yeah, thank you. I think that we are moving in an era where no matter what we do, this flexibility is becoming more important now, and trying to be more authentic. The only thing is we cannot control all the environment. I guess that's where we are.
It is my biggest pain point, is far and away, is what we're seeing. Is it drift, or is it growth? Is it really growth and adoption? Probably it's some combination of the two, right? I do think the content does find its way out there. I don't think most people are looking for the content. And I don't think most people are trying to game that system. And it's pretty low stakes, to engage in this process, to do it kind of at your own pace. Are there some that will take a circuitous route just to pass because there are some consequences at the end? There's some, but I think there are far less, given kind of the way that we've structured the exam. We do have a study at NCME this year that is looking at drift over time using a couple of methods, the RIPD method. I was discussing on that paper with Chris Hahn last year, and I was like, I'm totally stealing this to look at drift on our longitudinal, and some other diff-like methods to see, do we see drift from quarter 1 to quarter 2, quarter 1 to 3 to 1 to 4? Are we seeing items get easier over time on those first attempts only? That would be some evidence that the content is out there. And we see some of it, but it's not compelling or overwhelming evidence that those items are drifting. So we're doing our best to try to gather evidence that what we're seeing is learning and growth and not cheating or item exposure. But it's an ongoing, everyday battle that we're gathering that evidence.
Yes. I appreciate it.
Sure.
Josh. Yeah.
Yeah, I can't imagine how much time and energy and effort you must spend on item development, knowing that you burn through 700 a year, roughly speaking.
Yeah, it's like you're reading my mind. 2 slides later, our biggest barrier, it's related to item development, without a doubt. I mean, items are so hard to create. They take so much time. We rely on PAs. They write items, they come in, they review them. 700 items we write. These items have critiques. They come in sets of 3. Like, it couldn't be harder to create a set of content. We rely on external expertise to do that, plus our own staff. And then at the end of the year, I save 10 out of the 150 topics we create so we can equate, and the rest go in the garbage. So 600 items out of the 700 we create are gone. And it is painful and sad to watch that happen. But right now, we don't have shortcuts to do that. We do have some things that we've been doing. We are trying to use some AIG work. Dr. McKinday helped us do a study with some AI several years ago during a internship that we're using now to do a little bit of work in this area to see, can we generate things faster? Do we gain anything? The short answer right now is I don't think we're more efficient with AI in terms of generation. It shortcuts some of our editorial steps though, right? So from a workload perspective, for me, if I look at my content developers, they like it better because there's less to edit. Are we doing things faster? No, but maybe the reduction of effort on our end is enough of an efficiency gain that we take the edge off of some of the pressure to produce. Right. So we're looking at things that we can do to make this more efficient for sure. One of my favorites, and it's way down because we haven't done the study yet, is maybe we don't need to remediate every item with a partner item, right? Writing 3 items per topic slows down how much content we can create, right? A lot of that is redundant content There's some really interesting models. The sequential IRT model, it's a model that's been around a long time. Alison Chang at Notre Dame wrote a nice paper a couple of years ago with a student that looks at this from a multiple attempt standpoint, which is essentially we parameterize, attempts after the first attempt. So you answer a question and I say, you got it wrong, try again. And that second attempt is a scoreable item with a different set of item parameters. So we can essentially remediate with that same item. Now, maybe if you choose the wrong answer twice, we say, we're going to remediate you on this one. You get a topic that is going to be repeated at a later point in time. But maybe for that first attempt or for some items, we can give you that second attempt. I don't have to write 2 items. One thing we hear from a lot of PAs is I really had it down to 2 options and I just didn't know. Both good choices, I didn't know. We've done our job as item writers. That's what distractors should do, but they get it wrong. If they have really narrowed it down to 2 and they get one wrong and they immediately go and choose that next one, maybe that's remediation enough for that point in time, for that particular circumstance. So there's some other modeling things that we're trying to do to reduce our burden. If I could write less partner sets, if each partner set had 2 instead of 3, that means that I can write way more content on more topics, or I can reduce our item writing total each year by about 1/3, which would be significant in terms of what we have to do. So there's some things we're looking at to try to make that more efficient for sure. I could talk for another 3 hours if you guys have the time on all the stuff that we would like to do. I know that you're probably 15 minutes over, and some of you, I'm sure, have things to do, or Hope's got comp set he's got to write. So, are there other questions I can answer for you guys?
Yeah, I mean,
I think one question I do have is you mentioned it as part of growth and pain. It's the use of AI and in relation to test security. Is there anything you're doing now to curb that situation?
So I think the use of AI in content development just allows us to do more frequent refreshes of our bank. If we could get to a spot where we were highly effective and efficient in producing content, I could publish a new item bank every quarter instead of once a year with the same amount of effort. I don't think we've gained that efficiency yet. I have hopes that we'll get there, that we'll be able to refresh quicker, faster. I do think there are some other things, Henry, that would help us along those regards. If I could use, a bot to help me write the rationales and critiques after the items have been approved, that's time that my item writers aren't writing, and it's time my content development staff isn't spending, which again means that maybe I can write more items in here because we're not writing that part. That might mean that we can then produce more items, make the bank bigger, release the bank in increments. Each quarter it's released with an overlap, and I'm doing some scaling and equating work at that point, right? We could use AI in other capacities. Like I would love to be able to have starting estimates of difficulty when I start the quarter. That'd be great. Then I could score people immediately. If I do release banks over time, I would have starting estimates where I could give preliminary scores. Remember, this is a long process. I'll have final scores and final item parameters at some point. So it's not like I can't change that. Maybe, doing more difficulty modeling or producing a little army of chat bots to interact with my content at various levels of proficiency. And we can use that as starting responses and calibrate and have starting values of difficulty. That would let me release little bits of the bank over time. That would help with test security. So I think there are lots of ways that AI could plug into bolstering test security. We're just not there yet, not as a field and definitely not as an organization. For me, it just means I need more people to do more research. It's hard to find time, my operational psychometricians, it's hard to find time to engage in those studies on a persistent basis and kind of act on it. It just takes us time to get there. But I do think that AI capabilities are going to do lots of things to help us ease security, whether it's data forensics, content generation, easing content generation, doing things to help us find better difficulty estimates so we can release items quicker, faster, less pretest time. All of those things are going to help us for sure.
Thank you, Dr. Goodman. You said you had 30 slides, right? I think we can just finish it up.
Oh, I have so many more slides up. I won't even go through them all.
Okay.
We'll go to the question slide. Two things that I think are interesting that we are going to start working on. One is that I think we're going to move towards a more adaptive framework for assembly of exams. That's on my radar for the next release, an on-the-fly multi-stage release. So it would be targeted at an information curve for each individual, assembling the panels all at once. It would let us select remediation items and other items all at once to meet an overall information target, which would be beneficial for those remediation topics. Right now, it's awkward combining the psychometric information. We can have a second session. Yeah, Fridays are good for me. I'll come back anytime. So we got some neat things that I think are coming for sure. And that I am really going to go to my question slide now that we've been having questions, and I'm glad to talk more one-on-one. You guys can reach out. If you're at NCME ARA coming up, I'll be there Friday and Saturday. We can always catch up then. We'll be doing our normal UNCG social that I help plan. We were slow finding a place this year, but that flyer should be coming out soon. I'll make sure I circulate it to anybody and everyone that's interested. You can all receive that and then pass that on to other students, but I'll be there and we can talk about this stuff there as well.
Thank you very much, Dr. Goodman. Does anyone have any final questions? Sorry, we took your time a little bit.
Yeah, no problem at all.
All right.
No, but thank you very much for being here.
Yeah, I just want to say a big thank you, Josh, for supporting this department.
Oh, absolutely.
We need as much support as we can, and it's been very nice to see, folks from like Drew, and I can't remember who else. I mean, just being here and being able to chat. Yes,
it's like an alumni chapter. I've hired an alumni chapter,
and it just makes those who are in the program get to know others that we talk about many times but never get a chance to see them in action.
Absolutely. Yeah, anything we can do to help support, I know I'd speak for a large group of alumni that like coming back and like maintaining that connection. We like meeting, the students who are in the program now and sharing stories and it's all great. So anything I can do to help, anything we can do to help.